بسم الله الرحمن الرحيم. برحب بحضراتكم في مراجعة موديول الماسكولوسكليتال في الدبلومة رقم 5 أونلاين. وزي ما احنا متعودين بيكون في مجموعة من الحالات واحنا بنعرضها على حضراتكم وانتوا بتجاوبوا على الشات، وبعد كده أنا بعقب على الإجابات بتاعت حضراتكم. هنبتدي الأول ديت أول حالة، وهي عبارة عن إكس راي على البلبس مع حد بنوتة صغيرة في السن. As you can see, and the epiphysis is not yet closed. And what do you think about the diagnosis? Okay, and if you look carefully here, and you can see that there is some rarefaction of the pelvic bones, and you can also identify that there is what's known as the loser zone, or the pseudo fracture at the femoral neck on the left side, and another one on the right side. And these are pathognomonic, of course, of osteomalacia. And you know that osteomalacia and osteoporosis are one of the metabolic bone diseases where osteomalacia there is deficiency of vitamin D. In osteoporosis there is deficiency of calcium. The manifestations of osteomalacia are predominantly in the decreased bone density and bone softening. You can see protrusio stabili, you can see loser zones, or what's known as pseudo fractures at some of the characteristic locations. Next case is an MRI of the ankle, and this is coronal T1, and this is sagittal stare. Okay, I have to wait for some time, then I answer by myself, because you know the problem of electricity. And this is osteochondral defect. Okay, this is a vascular necrosis of the talar dome. You see a large area of necrosis, which is bordered by the line separating the dead bone from the viable bone. And you know that there are 4 grades of avascular necrosis of the talus. Grade 1, bone marrow edema. Grade 2, isolated necrotic bone which appears cystic on MRI. Then separation of the necrotic bone, then displacement of the necrotic bone away from the site of separation. And this is according to the grading system in avascular necrosis grade 2, because the bone appears cystic, as you can see here. Next case is a thoracic CT scan of a child, as you can see, and there are multiple lesions in the ribs. Okay, and this is extramedullary hematopoiesis. The answer is right because there is evidence of marrow hyperplasia with expansion of the medullary cavity of the ribs associated with extraosseous soft tissue components representing the hematopoietic tissue of extramedullary hematopoiesis. Next case is an MRI of the ankle, and this is a sagittal stare image. Yes, and this is Haglund syndrome. The answer is right. There is swelling of the Achilles tendon with intrinsic abnormal signal, inflammation of the retrocalcanean bursa, as well as inflammation of the subcutaneous tissue superficial to the Achilles tendon. This is the triad of Haglund syndrome. Next case is an MRI of the shoulder, sagittal T1, and the coronal gradient image. Okay, and this example, they can easily appreciate that the inferior glenohumeral ligament is considerably thickened and is also very short. And another finding is that the coracohumeral ligament is markedly thickened with obliteration of the fat in the rotator interval. And these findings are diagnostic of adhesive capsulitis or frozen shoulder. This is the normal appearance of the coracohumeral ligament, and this is the fat in the rotator interval, which is the space between the supraspinatus and the subscapularis muscles seen in the sagittal image. The findings of adhesive capsulitis on MRI are: number one, thickening and shortening of the inferior glenohumeral ligament; number two, thickening of the coracohumeral ligament; number three, obliteration of the fat in the rotator interval. Next case is an X-ray of the ankle. Okay, this is not myositis ossificans, but this is the Charcot joint, and you see the severe disorganization of the ankle joint with extensive increased bone density and the bone fragments, disturbance of the alignment of the joint. All these are known as neuropathic joint, or the Charcot joint, which is the sequelae of decreased blood supply, decreased sensation, and the superadded infection, which are commonly seen in diabetic persons. Next case is an X-ray of the hands. No, this is not scleroderma, but dermatomyositis. The answer is right, dermatomyositis. This is not melanocytosis, but these subcutaneous calcifications along the short bones and also seen in the thigh. But this is not scleroderma because one of the essential findings of scleroderma is resorption of the terminal phalanges and contraction deformities of the joint. This is dermatomyositis. Next case is an MRI of the knee joints, and there is a problem on the right one. Yes, the answer is right. This is lipoma arborescens, and you got a big mass of fat signal within the distended joint capsule by fluid. The fluid is of black signal in the T1, bright in the stair. The fat is of high signal in the T1 and is dark in the stair. This is the classic appearance of lipoma arborescens. Next case is an MRI of the knee, and this is sagittal T1 and sagittal T2, and this is I think is T2 also, but this one with fat suppression. And the last image is contrast enhanced image. Yes, and this is pigmented villonodular synovitis. This is right, because if you are thinking of hemophilic arthropathy, then these dark signal lesions will not enhance with contrast. But in cases of pigmented villonodular synovitis, and you got contrast enhancement, and this is one of the essential differentiating points between hemophilic arthropathy and pigmented villonodular synovitis. This is an MRI of the shoulder, coronal T2 fat set. Yes, and this is right answer. This is supraspinatus partial tear, and the tear here is on the bursal surface of the tendon. The articular surface of the tendon is intact, while the bursal surface is ruptured. And this type of tear is relatively uncommon compared to the articular surface tear. X-ray and the coronal stear of the ankle joint of a female patient, 20 years old, with localized medial ankle pain. She sustained an ankle sprain while playing football 5 months ago. Tibia ligament tear. Okay, and then this circle identified the site of the medial collateral ligament or the deltoid ligament of the ankle. This ligament is fan-shaped and is of dark signal, but here you can see that the ligament is bright in the stair image together with bone marrow edema at its attachment to the talus, and this means that the ligament is sprained, or you may say injury to the deltoid ligament. Next case is an axial MRI of the shoulder, stir images. No, this is not Bankert lesion. The anterior labrum is intact, but the affected is the subscapularis tendon, and the subscapularis tendon is torn. It is not reaching its insertion site in the lesser tuberosity, and the cause of tear is seen in the image because the distance between the coracoid and the head of the humerus is very narrow. Normally, this distance ranges from 8 to 11 millimeters, but here it may be only 2 millimeters, and this is known as a subcoracoid impingement. When the distance between the coracoid and the humeral head is narrow, this is known as subcoracoid impingement, and this is one of the reasonable causes of tear in the subscapularis tendon. Next case is an MRI of the shoulder with arthrography. Banker to heel sacks. No, this is not right. But if you look carefully here, you see that the middle glenohumeral ligament is very thick. The anterior glenoid labrum is hypoplastic, and these two findings contribute to the buffered complex, which is considered by many as a normal variant. Whenever you see that the middle glenohumeral ligament is thick, then you expect that the anterior labrum is hypoplastic, and this is bifid complex. Next case is a child, 11 years old, with a lesion in the radius. Yes, and this is ABC, or aneurysmal bone cyst, which is very similar to a finger in a balloon, meaning that the transition zone between the lesion and the normal bone is very narrow. And this is not seen in simple bone cyst, for example, but is well evident in aneurysmal bone cysts. Next case is an MRI of the elbow of a male patient, 60 years old. Contusion of what? In this example, the abnormality is in the common extensor tendon, which is swollen and showing abnormal signal, and this is known as lateral epicondylitis or tennis elbow, as you know. Yes, and this is any abnormality in the common extensor tendon, swelling with abnormal signal, partial tear, complete tear. All these changes are referred to as lateral epicondylitis or the tennis elbow. Next case is a female patient, 29 years old, with a big mass infiltrating or involving the right iliac bone. Yes, the answer is right. This is chondrosarcoma, not Ewing, because the patient age is a little bit old in the adult. Ewing sarcoma is seen more commonly in the pediatric age group. Also, whenever you see a malignant mass with matrix calcification in the tumor tissue, then you think of chondrosarcoma, and this is chondrosarcoma of the iliac wing. Next case is an MRI of the knee coronal image. No, this is not migratory osteoporosis. The edema is not that big, and is not also an ACL tear nor a lateral collateral ligament injury. If you look carefully here, then you see this is the posterior cruciate ligament, meaning that this is the medial condyle of the femur, meaning that this is the medial meniscus, and the medial meniscus is divided into two parts, a peripherally small part and a displaced meniscal fragment lying inferior to the posterior cruciate ligament, which is seen in the sagittal image as the double BCL sign, and this is diagnostic of bucket handle tear of the medial meniscus. Of course, in the clinical practice, you can easily appreciate the diagnosis from the sagittal image. But in the exams, you know that they are trying their effort to mislead you, and this is one of the possibilities that you are provided with the coronal image, not the sagittal image. Next case is an MRI of the ankle, and this is T1 sagittal, T1 coronal, and T stir image sagittal. Yes, bone infarctions, and this is the answer is right. The infarctions affected the tibia as well as the talus, and you can see that there are similar identical lesions like those in the distal part of the tibia, and these are bone marrow infarctions. Next case is a football player with locking sensation and pain in the knee. He is 18 years old. No. Yes, osteochondritis dissecans is the right answer. And here you see the ACL is good, but you can see a separated bone fragment from the femoral condyle, which is hardly seen in the plain film, but can be easily appreciated in the coronal image. This is a classic appearance of osteochondritis dissecans. MRI of the shoulder sagittal T1 and the sagittal stare. Coracohumeral ligament tear, rotator interval tear. But in this situation, you see that the coracohumeral ligament is not identified, and the rotator interval is obliterated. The fat is obliterated by abnormal tissue, which is a blue signal in the T1 and a bright signal in the T2. And this is, as I have said, represents one of the findings of adhesive capsulitis. And usually patients with adhesive capsulitis, whenever they are examined by MRI, we concentrate on the inferior glenohumeral ligament in the coronal image. But we usually forget to look at this site, which is more pathognomonic for the diagnosis of adhesive capsulitis. You should look for the integrity of the coracohumeral ligament, and you should look for the clear fat plane in the rotator interval. Next case is an X-ray and MRI of the knee joint. Yes, and this is a classic appearance of aneurysmal bone cyst with multiple fluid levels. Next case is a male patient, 30 years old, with a mass in the distal part of the thigh. Yes, parosteal osteosarcoma, you are right. This is the right answer. Parosteal osteosarcoma is a big mass of bone tissue that is related to the periosteum or the cortex of the bone. Sometimes it can be mistaken for myositis ossificans even by histology, but for the diagnosis of myositis ossificans, you need the history of trauma, and you know that the site of myositis ossificans is usually anterior to the femur, which is the common site to be traumatized, while this lesion is a little bit lateral. Next case is a female patient, 30 years old, with a lesion in the tibia. Yes, and this is giant cell tumor. It is not an aneurysmal bone cyst because number one, the epiphyses have been closed, meaning that the patient is old, more than 20 years. Then you got an expanding lesion and touching the articular surface of the bone, with no periosteal reaction and no extra osseous soft tissue components, then you think of giant cell tumor. Next case. And this is MRI of the, yes, and the answer is good. This is Brodus abscess, T1. T1 with contrast fat set, and this is T2 weighted image, and you got an intramedullary abscess with surrounding bone marrow edema, and you should remember that bone marrow edema of whatever etiology will enhance with contrast material. This is a classic appearance of Brodus abscess. Next case is an X-ray of the hand and wrist of a female patient, 56 years old. Okay, and you can also see the MRI of the same case, axial T1 and the coronal stair. No, this is not hyperbara, and this is not a crowded corpus, and this is not osteoarthritis, and this is rheumatoid arthritis. Of course, and you see that there is marked erosive changes in the distal part of the ulna, some erosive changes in the carpal bones, a marked narrowing of the radiocarpal joint, some joint effusion and synovial thickening. And synovial thickening is usually appreciated much more if you inject contrast material, but this case is presented to see the discrepancy between the X-ray and the MRI findings. And at this point, the rheumatologist usually insists for this to see the erosions at a more earlier stage so that they can be able to treat the patient and to prevent complications. Next case is an X-ray of the hand. No, this is not all year, but this is Mahfouz syndrome, and you got multiple inchondromas, as well as calcified fibrillary in the soft tissues of the hand, diagnostic of hemangiomas, and hemangiomas and inchondromas contribute to the diagnosis of Mahfouz syndrome. And this is an X-ray of the wrist joint. Yes, and scaffold unit disruption. You see that the distance or the scaffold unit interval is markedly wide, and this means that the ligament in between is torn. The scaffold unit ligament is ruptured, and this is the MRI, which you can also see the same finding. The scaffold unit ligament is not there. Its site is occupied by fluid with displacement of the scaphoid and urinate away from each other. Next case is a child. The epiphysis is not yet closed, and okay, the previous case, negative ulnar variance. Okay, and this is diaphyseal achalasia or hereditary exostosis. You got multiple osteochondromas with abnormal bone remodeling distributed throughout the skeleton. Next case is coronal CT of the sacroiliac joints and the axial T1 fat set with contrast MRI. Yes, this is infection, and you may call it septic arthritis of the sacroiliac joint. There is destructive changes in the articular surfaces of the joint associated with marginally enhancing collection surrounding the joint, representing an abscess. And as you know that unilateral sacroiliac joint affection is one of three. Number one, trauma. Number two, infection. Number three, tumors. But bilateral sacroiliac joint disease has a very long list of differential diagnoses. This is septic arthritis of the sacroiliac joint. Next case is an MRI of the ankle when the patient had history of trauma, and this is the axial T1 and axial T2 fat set. Lipoma, no. Where is the lipoma arborescens in the ankle? No. Any other suggestions? Yes. What about the tibialis posterior? Fasciitis? No. Okay, if you look carefully here, you may see that the tibialis posterior tendon has been dislocated from its anatomic site. Usually, the tibialis posterior tendon is here, and this is the flexor digitorum, and this is the flexor hallucis. But secondary to trauma, the tibialis posterior tendon has been dislocated anteriorly, and there is some fluid signal around the tendon which may contribute to tenosynovitis of the traumatized tendon, but the tendon is intact with no abnormal signal inside. Next case is an MRI, is an X-ray of the hand showing a lesion here in the phalanx. No, this is not sarcoid. Paget, yes, Paget is right. Paget disease is the only disease which increases the size of the affected bone. Then if you look carefully for the phalanx and you compare it to the adjacent phalanges, you can easily appreciate that this phalanx is big and it has a coarse trabeculated pattern, which is diagnostic of Paget's disease. Next case is a female 16 years old with a lesion in the tibia. Yes, and this is chondroblastoma, and the right answer. This is a very big lesion to be considered as a GID, but the patient is young, and there is a lesion in the epiphysis, and this lesion is cystic, surrounded by bone marrow edema, or with a sclerotic margin and maybe some foci of internal calcification, and all these criteria are supportive for the diagnosis of chondroblastoma, which is the only epiphyseal lesion. Next case is an X-ray of the hand with a lesion in the proximal phalanx of the index finger. No, this is not TB, of course. No, it's not Ollier. Yes, chondrosarcoma is the right answer you got here. A destructive lesion with big extraosseous soft tissue component, and the component contains matrix calcification, and this fit well with the diagnosis of chondrosarcoma. This patient was misdiagnosed as gout. Of course, this is not by any means to represent gout. Next case is a male patient, 30 years old, and this is CT scan of the leg. This is the tibia, and this is the fibula. Osteosarcoma, no. Malignant change of exostosis, there is no exostosis originally. No, this is not myositis. But if you look carefully here, and you see that there is a big mass of fat density, and this mass is intimately related to the posterior aspect of the cortex of the tibia, with some bony extensions through this fatty mass. And this is not liposarcoma, of course, and this is paraosteal lipoma. Yeah, you remember from the lectures of soft tissue tumors that paraosteal lipoma is a mass of fat tissue that is adherent to the bone, and because of its intimate relation to the cortex of the bone, it will initiate some sort of bone reaction, and this bone reaction will appear as bony strands going through the lipoma itself. and frequently, especially from the plain film, it may be mistaken for a malignant lesion. But this is an absolutely benign lesion, which is parosteal lipoma. Next case is a female patient, 37 years old, with a mass in the region of the right hip joint. And the provided differential diagnosis include metastasis, lymphoma, synovial sarcoma, leiomyosarcoma, and septic arthritis. Lymphoma, septic arthritis, these are the provided answers. Mets, another suggestion. Okay, all what I intend from the presenting this case is to teach you how to handle the differential diagnosis of a mass. Actually, you may not be able to reach the definitive histologic diagnosis of some of the lesions, like this one. But if you follow some of the rules provided through the lectures, and you know that this is an adult patient with a destructive lesion in the pelvis, and the possibility of metastasis is there. And you know that included in the differential diagnosis of metastasis lymphoma and the primary tumor that can arise here, which is most likely a synovial tumor representing synovial sarcoma. But it's very important not to mistake this lesion as septic arthritis. There is no signs of inflammation here, and there is the hip joint, the femoral head is intact. And for the diagnosis of arthritis, the both articular surfaces, the acetabulum and the femoral head, should be affected. But here, the main front of the lesion is located intra-articular with extra osseous soft tissue component. Then if you say that this is metastasis, you are right. If you say that this is lymphoma, this is good possibility. But this lesion was proved by biopsy to represent a synovial sarcoma. Next case is a mass in the gluteal region, and this mass is of low signal in the T1, very bright signal in the T2 fat set, and this is supposed to contrast T1 fat set. Yes, this is a straightforward case of hemangioma. Hemangioma is very, very bright in the T2. And through the hemangioma, you can see some linear bands inside the lesion, which represent fibrous bands. And if you see dots of black signal, they may represent calcified fibrobuli. And nothing of the soft tissue tumors can reach this very high signal in the T2 weighted images, except the hemangioma. Yes, and this is what is the iliac bone is just a reaction to the presence of the tumor adjacent to it, and this reaction is of bright signal in the T1 and dark signal in the T2 weighted images. And hemangioma is enhanced actually, and you don't expect an extensive or very prominent enhancement in the hemangioma arising within the soft tissues of the extremities. The hemangioma which enhance very strongly is that is in the head and neck, especially in the parotid. But the musculoskeletal hemangiomas, this is usually the pattern of enhancement, whether it is intra-articular or within the soft tissues of the limbs. This patient had old history of trauma, and you can see a mass in this coronal T1, and this is T2 or stair, and this is post contrast. Actually, the myositis ossificans is the right answer. But actually, the diagnosis of myositis ossificans without the presence of the plain film is very, very difficult. And you may mistake this for tumor or even an abscess with surrounding soft tissue edema. But in the presence of positive history of trauma, and if you have the X-ray and you see that the lesion is at a classic site, which is the anterior aspect of the lower thigh, then you may think of this possibility, which is myositis ossificans. Then this is MRI of the shoulder, and this arrow points to one of the ligaments, which is known as the coracoacromial acromial ligament. This ligament is hypertrophied, as you can see, and it is considered as one of the causes of impingement. There are a lot of causes of impingement in the region of the acromioclavicular joint, and they usually correlate this with the keel spur, and this is the keel spur of the boat, and the causes of impingement syndrome at the region of the acromioclavicular joint include: number 1, acromioclavicular osteoarthritis; number 2, acromion down slope compared to the level of the clavicle; number 3, subacromial osteophyte, which is exactly similar to hypertrophy of the coracoacromial ligament; and number 5 is the type 3 acromion with anterior hook. So many of these factors can cause impingement and consequently can cause supraspinatus tendinopathy. Next case is X-ray of the pelvis and the hip joints of a child, and also a selected image from contrast enhanced CT of the same case. Yes, and this is septic arthritis of the hip. And here you can see haziness around the hip due to soft tissue edema and soft tissue infection as well. But if you have the chance to see the femoral head and the acetabulum, and you may see some erosive changes in this particular area, which can support the diagnosis of septic arthritis of the left hip joint. This is an X-ray of the left hip joint showing some changes. No, this is not osteoarthritis because one of the avascular necrosis is the right answer. One of the essential findings for osteoarthritis is this finding, which is narrowing of the superior lateral aspect of the joint space. And without this finding, be cautious to diagnose osteoarthritis. And here you see that the femoral head is partially collapsed, and you got areas of bone rarefaction with areas of bone sclerosis, contour irregularity. All these findings are diagnostic of avascular necrosis of the femoral head. Then you know that avascular necrosis can be complicated by secondary osteoarthritis. At that time, you will see that the superior lateral aspect of the joint space is narrowed, and the diagnosis at that time is osteoarthritis. And you don't have the right to say that this is on top of vascular necrosis or on top of so and so. You are dealing actually with a final diagnosis, which is osteoarthritis. Then this is a female patient, 59 years old, with medial knee pain for 1 month. And this is X-ray of the knee, MRI coronal stair, and sagittal T1 weighted image. Yes, the answer is right, and this is SONC. And by SONC, we mean spontaneous osteonecrosis of the knee. And this is seen in all patients with some osteoporosis, and there is flattening of the articular surface of the medial femoral condyle with some collapse and bone marrow edema. This is quite different from osteochondritis dissecans, which affects young persons, and there is a separated necrotic bone fragment, and this is different. This is also a type of avascular necrosis, but it is known as SONC, or spontaneous osteonecrosis of the bone. شكرا جزيلا لحضراتكم. وكان في مجموعة من الأسئلة اتبعتت لي، بس أنا الحقيقة ما تمكنتش إن